assign specific and precise CVP values to different patterns of IVC size and collapse, but we moved away from that, and now we use the American Society of Echocardiography's recommendations, where we basically say if a IVC is small and collapsible, defined by less than 2.1 centimeters in diameter, and collapsing more than 50% in a spontaneously breathing patient, then we assign the right atrial pressure of 3. If somebody has a large and uncollapsible IVC, so greater than 2.1 centimeters and collapsing less than 50%, we assign them the estimated right atrial pressure of 15, and everything else, any other combination of size and collapsibility, we assign the right atrial pressure of 8. We also tend to follow their guidelines that say that if a patient is on positive pressure ventilation, we assign them a right atrial pressure of 8, regardless of what their IVC dynamics look like. As we do this, though, I want to make sure that we're not inappropriately narrowing our differential to only thinking about their volume status, because IVC plethora is a non-specific finding. Many things will cause a large non-collapsing IVC, and that includes tamponade physiology, as we just mentioned, as well as multiple different types of cardiomyopathies or pericarditis, massive PE or tricuspid regurgitation. And IVC thrombus is a rare, but in my institution, sometimes seen phenomena where the IVC will be large even though the patient is relatively hypovolemic. Beyond that, even IVC collapse is nonspecific. We've all seen the patient who's got severe dyspnea and their intrathoracic pressure swings are so great that their IVC will collapse regardless of what their intravascular volume status is. And similarly, you can have something externally compressing the IVC, such as a mass or tense ascites causing a small or collapsing IVC in a patient whose volume status would suggest they have an elevated right atrial pressure. So here's an example of video like this I tend to use for teaching. You can see the IVC in the longitudinal view. You can see it draining towards the right atrium. You can see liver on both sides, and you can see a hepatic vein starting to go into this. And you might look at this and say, oh, this IVC is about 2 centimeters and is not collapsing at all. But you also, if you have a keen eye, can see around the heart an anechoic space. And when I rotate my transducer, I'll see that that brings me again to a large pericardial effusion. So when we think about the IVC and the internal jugular vein, we get to see patterns of these that correspond if you have an IVC that's not achievable. And many times in our critically ill patients, we can't see the IVC because of ileus or bowel gas or surgeries. So if we think about plethoric IVCs, as you can see here, large, unchanging, normal IVCs or flat IVCs, we have a correlating internal jugular pattern where high on the neck, you can see here a dilated IJ, much bigger than the carotid, not changing with respiratory variation. Here you can see a normal IJ, where even just above the clavicle, you have a triangular, a trapezoidal shape that changes in size with respiration. This represents a normal right atrial pressure. Or here you can see somebody who just above the clavicle has a completely collapsed IJ that only expands during exhalation. So if we put that together into our table, now we've got our third column. Thinking about our etiologies of shock, we can think about the fact that a hypovolemic or hemorrhagic shock patient should never have a plethoric IVC absent one of the confounders that we just talked about. Instead, their IVC or their IJ should be flat. Cardiogenic shock patients tend to be volume overloaded, so they tend to have plump IJs and IVCs. Obstructive shock patients, similarly, the blood has to back up somewhere. So if an obstructive shock patient is evaluated, they should have a dilated neck vein and a dilated IVC. And distributive shock patients, it depends on what phase of resuscitation they're in. Prior to resuscitation, these vessels are flat, and then normal, and then plethoric if they are resuscitated. So that's our venous filling. Let's talk about the pulmonary window as a way to get an idea of what's going on in shock. The first thing we can do is we can look for pneumothorax, and we do that primarily through lung sliding. And if you look at these two videos, one done with a linear transducer and one done with a phased array transducer, you can see the glistening, shimmering artifact at the level of the pleura that's highlighted here in the white box. I'll offer that if you're a computer nerd like I am, you might see this and say each pixel is just going black, white, gray, black, white, gray, black, white, gray over the course of a respiratory cycle. And the presence of this finding, of this shimmering artifact known as lung sliding, rules out a pneumothorax at the place where the transducer is being held with a greater confidence than a chest x-ray interpreted by a radiologist. Sometimes that lung sliding artifact is difficult to see, or if you have a patient where their lung's not moving very much, for instance, somebody who has bullous emphysema or has low tidal volume ventilation, you can look for the lung pulse. And what you're seeing here is in the M-mode imaging version of evaluation for lung sliding, you can see a break in the horizontal lines, highlighted by those white arrows, or here on this longer spectrum. And this allows you to see that every time the heart beats in the chest, it causes the two layers of pleura to move against each other. So even though there's no respirophasic variability of the pleura, there's still a cardiophasic variability. And that allows us to rule out pneumothorax with the same confidence as seeing respirophasic lung sliding. So if we put these together, we have lung sliding, the presence of B lines, which cannot be seen if there is a pneumothorax, and lung pulse. We start to get a pretty robust set of indicators to rule out pneumothorax in a patient with undifferentiated shock. There's only one finding described in the literature as ruling in pneumothorax, and what it's seen here, it's referred to as the lung point. And what you can see is that there is no lung sliding in the pleura on the left-hand side of the screen, but there is lung sliding in a respirophasic pattern on the right-hand side of the screen. This suggests that we're seeing the bottom edge of the pneumothorax. I'll offer that you can see this finding, although it's described as being 100% specific, in patients who do not have pneumothorax if they have a history of thoracic surgery. For instance, in my center, with a large number of lung transplant patients, we frequently can find a lung point in a patient with no pneumothorax. It's also not very sensitive. If we think about the size of pneumothorax that tends to cause tension in physiology, it's circumferential, large pneumothoraces, as seen here in this chest x-ray. And that means you're never going to find the point where the lung re-adheres to the pleura. The next step of my lung evaluation with point-of-care ultrasound is looking for B lines. And what I'm looking for is whether there are these vertical hyperechoic artifacts and what their pattern is. You'll also notice that on the left we have a smooth pleural line, perfectly smooth white line with B lines coming off of it, whereas on the right you have a little bit more of a jagged pleural line. These are referred to as an irregular pleura. That irregular pleura suggests that it's an inflammatory or infectious etiology of the B lines as opposed to purely a volume overload etiology in comparison to the smooth pleura here. Lung ultrasound is useful not just for the presence of cardiogenic or non-cardiogenic pulmonary edema, but also for the detection of pneumonia. So if we think about focal B-line patterns as being present in our pneumonia patients, or potentially a consolidation as seen here with a small pleural effusion in this patient with strep pneumonia, or the dynamic air bronchogram seen here where you can see these white lines moving with a respirophasic pattern in a patient who's got pus in the airways. These things all make lung ultrasound a better diagnostic tool for pneumonia than plain chest x-ray. Beyond just the pneumonia, you can evaluate for whether there's a closed space of infection, like empyema. If you look closely at this image, you can see the consolidated lung, you can see the hypoechoic pleural effusion surrounding it, and you can see a couple of loculations connecting that consolidated lung to the diaphragm on the right side of the screen. That suggests pretty strongly that this is going to be an exudative effusion. The absence of loculations does not mean that it's necessarily going to be transudative, but the presence of loculations was found to be very predictive of an exudative effusion. So now we've got our fourth column in this table. Pulling this together, we can think about whether we're seeing a diffuse A-line pattern, as we should see in a hypovolemic patient, a diffuse B-line pattern as is present in a cold and wet cardiogenic shock patient. Or we can see the specific patterns of obstructive shock, either the absence of lung sliding in pneumothorax, the A-line pattern of pulmonary embolism, unless you happen to catch the area of infarcted lung, or the A-line pattern of tamponade, where you have clear lungs, elevated neck veins. In a distributive shock patient, again, you might see A-line patterns or a pneumonia pattern, but gradually as they get fluid, you may see a B-line pattern start to appear as you get capillary leak into the lungs. Pulling this together, there's a few other windows that we can use to get some ideas of what form of shock a patient's in. We can do a DVT examination, and this is an example of a free-floating thrombus in a vein. And you can see that you want to check all of the zones of the lower extremity in order to have the confidence to say that you've truly ruled out DVT. Again, the absence of DVT does not mean that PE is off our differential, but the presence of DVT certainly raises our pretest probability. We can do skin and soft tissue ultrasound looking for infections. On the left, you can see a video showing the irregular borders, posterior acoustic enhancement, and hypoechoic space of an abscess. And on the right, you can see the cobblestoning pattern that typically is seen in cellulitis. Evaluating the genitourinary system, we can see here the hydronephrosis of a patient who had an obstructing urinary stone. And on the right, you can see a distended bladder with debris inside of it in a patient who had an undrained UTI, effectively acting as an abscess. Just looking at free fluid in the abdomen can help us, because if we see what we see on the left, loculated hyperechoic fluid, we start to worry that this too is an infected space. Again, an anechoic fluid does not rule out infection, and you have to do a paracentesis, and that's where ultrasound really leans into its strength as a procedural guide, seen here doing real-time ultrasound guidance of a paracentesis in a patient with a very small pocket. All right, now we've gotten through the first couple sections, and we can put together this pattern of the ways in which different POCUS findings correlate with different etiologies of shock. Beyond that, we can start narrowing it down and saying what things are different as we go from one form of shock to another. So the idea that if you find impaired function, that could be present in septic cardiomyopathy, but it makes cardiogenic shock think higher on my differential. Similarly, if we see a clot in transit or RV failure, PE is suddenly surged up. If we see a pericardial effusion, we have to think about pericardial tamponade. We want to think about the pattern of filling pressures and how those fit with different forms of shock. If I have a patient who I'm worried about hemorrhagic shock and I see a plump IVC, that moves down my differential. And conversely, if I see a patient where I'm thinking about obstructive shock, but I see a flat IVC or IJ, that moves down my differential. The lung ultrasound pattern can be helpful, especially if we're trying to identify a pneumonia that might have been missed on our chest x-ray. And then other findings such as free fluid in the abdomen, in a trauma patient, the presence or absence of pleural effusions, DVTs, or a source of sepsis can really help us figure out which type of shock we're dealing with. So let's take this on a bit of a test run. I'll show you some images, and we'll practice figuring out which form of shock these images would most appropriately be lumped into. So if we look here, we have a parasternal long axis view in the upper left-hand corner, a longitudinal view of the IVC in the right-hand corner, and a lung ultrasound view at the bottom. And if I look at this, I say, oh man, I see a large left atrium and a large right ventricle. I see a dilated LV, and I see a plump, unchanging IVC and B-line pattern. So when I put this together, I might think big RV, big LV, plump IVC, B-lines. That's cardiogenic shock until proven otherwise. If I see this pattern of findings, a dilated right ventricle, a dilated right atrium, a plump or plethoric IVC, and an A-line pattern, putting that together, I think, man, that works with PE, an obstructive physiology of shock. If I see this, a hyperdynamic heart, both left and right ventricles hammering away as hard as they can in that apical four-chamber view on the left. A flat IVC, you can see it draining into the right atrium with almost invisible diameter during inspiration. Or a consolidated lung as seen in this lung ultrasound showing a small pleural effusion surrounding it. To me that says normal or hyperdynamic heart, flat IVC, consolidated lung. I'm thinking about septic shock unless I have a reason to not. So where do we go from here? Now we've got a way to figure out which form of shock we're in. Let's talk about what we do next. And this is where we're going to talk about protocolizing our assessment of shock. And perhaps the most commonly used protocol is the RUSH protocol. And this can be thought of as an evaluation of the pump, the heart, the pipes, the IVC, the aorta, and the deep veins, and the tank, the pleural cavity and the abdominal cavity. Or this is sometimes thought of as high map, where you have the heart, the IVC, Morrison's pouch, the aorta, and the lungs. And this starts with a parasternal long axis view. You can see that being acquired here. And then you can move to an apical four-chamber view, because as I like to tell my trainees, one view is no view. You should always get two views of the heart before committing to your interpretation of it. A view of the IVC, looking to see whether that's big, small, collapsing, non-collapsing. Morrison's pouch, and the other chambers in the abdomen, with the understanding that Morrison's pouch is the most sensitive of those chambers for free fluid. An evaluation of the aorta to look for AAA. An evaluation of the lungs, primarily looking for pneumothorax as a source of obstructive shock. You can include other things such as ectopic pregnancy, which as an adult pulmonary and critical care doctor I'm very rarely looking for. Evaluation of DVT, trying to figure out whether or not I need to move PE higher on my differential. Beyond that, we can get into this interesting skill set of spectral Doppler interrogation of the aortic valve. And this allows us, through VTI evaluation, to look for whether we are in a low output shock state or a high output shock state. And so we think about this using that VTI, a measurement of the diameter of the left ventricular outflow tract, and in our minds, a typical normal range. And this one study from Sedig and Chest a couple of years back talked about the idea that if we have a VTI range of less than 14, that's a low output state, greater than 22, that's a high output state. And we need to think about that normalized to the heart rate. If somebody's heart rate goes up, we expect that each stroke is going to be smaller. The challenge here is when we think about all of our forms of shock, cardiogenic shock, obstructive shock, hypovolemic shock, and distributed shock prior to resuscitation, these should all be low cardiac output states. But the difference is that once you've resuscitated a patient with distributive shock, they go into a high cardiac output state. They have shifted, if we think back to those original couple slides, from a space of inadequate blood delivery to tissues to now there's adequate blood delivery, but unfortunately the cellular mechanisms or the microcirculation has been poisoned. We can use this serially, and this is where the real power comes in. And we can change ourselves from thinking, why are they in shock? We've already established that, to, is what I'm doing to them helping the shock? And so we can think about a hemodynamically unstable patient who start in this low cardiac output state for all of them, and then we do something. We either add inotropy or fluids, and we see whether that improves our cardiac output as measured via LVOT VTI. If we want to get an actual cardiac output instead of just LVOT VTI, the equation's here for calculating stroke volume using that diameter of the LVOT, and then we can multiply that by heart rate to get a cardiac output number. I'll offer that measurement errors in this get magnified because you're thinking about a radius squared value. So we can also just look at the VTI and scale it over time normalized to the heart rate. Here's an example. We have a patient who's got a VTI measured through that aortic valve of 11. That's low. This is a patient who's in a low cardiac output state. And then we can look at them after the intervention of adding epinephrine, and what we can see is they have improved their VTI. They now have a VTI of 15. They've moved closer to a normal cardiac output. One of the questions that's often asked is, can we use POCUS to answer whether or not a patient is going to be fluid responsive? And the answer to that is, it is better than a physical exam, but I want to highlight, as this graphic shows from DeBacher, that while we may still be on the part of the Frank-Starling curve where adding additional fluid to the patient improves cardiac output, we also could be on the part of the curve where there is steep increases with permeability of the capillaries. So while we're improving cardiac output, we're also causing more leaking into the lungs, that EVLW, extravascular lung water, which can cause more harm than benefit, especially if we already have adequate oxygen delivery to tissues. That said, there's a few different ways we can look at this. One is this idea of the underfilled left ventricle, and this is really referring to LV end diastolic diameter. And an excellent study by Vignon et al. In 2017 looked at this and said, hey, look, if you look at fluid responsive patients, patients who improve their cardiac output by 15% or more with a bolus, compared to not fluid responsive patients, the fluid responsive patients have a smaller LV end diastolic volume. The thing is that any 2D echo indicator we're using to look at fluid responsiveness is going to depend on them having normal diastolic function and normal valvular function. Also, it's going to be disrupted by any atrial arrhythmias, such as AFib. If we're looking at the RV measurements to decide whether or not somebody's fluid responsive, we have to assume that they have normal RV function and normal RV afterload. That said, when you take all these together and you compare them to clinical indicators alone, as was done in the study by Jack, asking cardiologists, do you think this patient has an elevated pulmonary capillary wedge pressure, versus echocardiographic indicators, the ones that we just described, they are superior to physical exam alone. Then we might ask ourselves, which indicator should I use? And this is where I'm going to go back to that study by Vignon et al. From the Blue Journal, where they compared a bunch of different echocardiographic indices to see whether or not somebody was fluid responsive. And I love this study. It's incredible and it's worth reading in detail, but buried in the supplemental tables is this one, which I think is just gold. And this is the idea that instead of having a single threshold value for any indicator, we want to have a recognition of whether we're trying to maximize that indicator's ability to be sensitive or specific. And you can see here a comparison between pulse pressure variability, the change in max velocity through the aortic valve, the change in size of the superior vena cava or the change in size of the inferior vena cava. And you can see that when you optimize this for sensitivity, you get very different values than their normal thresholds versus when you optimize it for specificity. And then you have this gray zone between the two. And that's the area where I should not change my pre-test to post-test probability. I do want to close by saying while we spend a lot of time and money trying to figure out how we can predict fluid responsiveness in our patients, I've started to care a little bit less than I used to. And if we think about the classic study that was released a couple of years ago, where they tried randomizing people to a more restrictive fluid strategy versus the standard fluid strategy, they found no difference in mortality or any of their other outcomes. Admittedly, this is probably a reflection of the fact that our standard of care has made it so that the difference in amount of fluid received by the restrictive versus standard group was a difference of only 1.5 liters, which is relatively small compared to when we look at historical norms. And this Clover's subgroup analysis shows that the practice is already changing. And when we really try to push people to be in a restrictive versus liberal fluid group, again, we see no real difference in outcomes other than the fact that the restrictive fluid group got more vasopressors, but we see a difference in fluids of about 2 liters. Again, making it so that I feel as long as you're within a range of appropriate fluid values, I'm a little less concerned in most patients. Those patients around the edges where I think another liter really will hurt them, or will they really be hurt by the escalating vasopressors that are on, those are the patients where we want to think about, hey, can I use POCUS in order to differentiate their fluid responsiveness status? So pulling this all together, I like to think of point-of-care ultrasound as an important part of the workup for shock. It augments the ability of our physical exam to see what someone's etiology of shock is and a little bit of whether or not they're adequately perfusing. We can use advanced techniques such as VTI to help us track whether or not our interventions are improving or worsening our cardiac output. And we can remember that patterns of point-of-care ultrasound align with certain clinical etiologies, which can really help us combine this with our history and physical to create a meaningful illness script. Thank you so much. Really excited to get to answer some questions about this and see how people are using POCUS in the field.
All right. Thank you so much, Dr. Baston. We do have Dr. Baston here on the call to answer questions. So we will go ahead and start the Q&A section now. Go ahead and put your questions in the Q&A box down below if you're on the Zoom stream. If you're on the YouTube or LinkedIn streams, unfortunately, we won't be able to take any questions from there. We can only do it on the main Zoom screen. So let me go ahead and get Dr. Baston on here. Dr. Baston, are you there?
I am. My camera says that it's disabled by the host.
Oh, sorry about that. Let me see if it go.
There we go.
Awesome. All right. So we do have a question so far. Miriam Jamil says, how do we interpret IVC diameters in intubated patients?
This is a great question and something that I really enjoy talking about when I'm in the hospital. If you ask the American Society of Echocardiography how to interpret the IVC for an intubated patient, they'll tell you you can't, and you should just assume that the estimated right atrial pressure is 8. And I'm not trying to disagree with that. It's the standard that's been used for all of the studies that have been done using echo to do things like right ventricular systolic pressure calculations. But I think we can get a little bit more sophisticated in our interpretation when we're talking about critically ill patients in a medical intensive care unit or really anywhere. And that means, what I mean by that is we know the direction of error. So positive intrathoracic pressure when somebody's on positive pressure ventilation, whether that's BiPAP or invasive positive pressure ventilation, should cause blood to pool in the abdomen. The IVC should become plump, should be bigger, and should collapse less than we're expecting. And so if I see a collapsing IVC, that means something to me. That means that this person doesn't have enough blood, even when augmented by the positive pressure ventilation, does not have enough blood to maintain their IVC as plethoric. On the other hand, if I see a plethoric IVC in an intubated patient, I don't know what to do with that. I go back to this should not affect my pretest probability. Now, if we go back to the Vignon et al. Paper, though, they did look at this in intubated patients, and what they specifically said is that you should have different thresholds. And that's where that one table that they pop up in in the supplemental table C, they have whether you want to maximize sensitivity or if you want to maximize specificity. And again, they're like, if you want to maximize the specificity of this, then you unfortunately have to use a change in IVC diameter of 3%, which, gosh, that's so subject to measurement error that I don't really end up using it all that often. But they say if you want to maximize sensitivity, you can use that 22%. And so again, it's with the knowledge of the directionality that the error should be moving based on positive pressure ventilation, we can get really useful information about inciting etiology. This all goes out the window if the patient is interacting with the ventilator. Spontaneous breathing on top of positive pressure ventilation makes it really tough to know what the pressure swings are looking like and how to quantify them. And then I just go to, this should not affect my pre-test probability of either etiology or volume responsiveness. But again,
Awesome.
great question.
Awesome. Yeah, we've got another one here. As a beginner using POCUS, how do you trust your skills enough to make a judgment to change management?
Another great question. I'll tell you, I very much remember the first time I picked up an ultrasound and looked at it, and I was like, this is definitely a molar pregnancy. All I see is snowy day and a polar bear. I have no idea what's going on. And I think that the hardest part right now is we're in this transition time where there's certain areas of concentrated expertise, places where you have lots of faculty who know what they're doing and can help supervise, and areas where there's just not somebody to help you out. The thing that I remember is early on in my career, somebody told me anybody who's serious about getting good at this keeps a portfolio of their scans. And I think that's the best advice I could give for a beginner is don't make clinical decisions based on this when you start. Make your clinical decisions based on the illness scripts, physical exam history that you trust. But as you develop your confidence and you have this portfolio that you can compare and you can go back and be like, oh, I thought that this ended up being hemorrhagic shock, but my ultrasound showed this. I need to learn how to put that together better. This is how you get to the point where you can trust what you're scanning. So just another like call out for building a portfolio, for finding somebody you trust to help you overread it, and gradually building up that confidence.
So, all right. Let's see. Do you have any other kind of tips and tricks that you use when you're scanning using POCUS?
Yeah, I mean, I think this was really focused on this idea that shock is an isolated etiology, and we all know that that's not what happens, and that people come in with multiple overlapping types of shock. So when you have your patient who has known heart failure and is septic, and you're trying to figure out which is the driver for this, these are times where sometimes you can use an ultrasound to spare your patient the right heart cath that would probably give you the answer. And what I mean by that is you get to see what's driving first. And the VTI is a great example of this. When I have a patient who's got a known heart failure with reduced ejection fraction, and they come in with what looks like sepsis, and I'm trying to figure out whether their hypotension is primarily driven by pump failure or if it's driven by sepsis and distributive afterload reduction, I like to be able to see two things. Number one, have I seen their ejection fraction improve from where it was before? Because if I think about it, gram-negative rod sepsis, I like to say, is a great afterload reducing drug. It makes it so easy, and you'll see people's ejection fraction augment in the setting of their sepsis. And you can say, all right, this plus maybe a central venous saturation of a central line, this points me towards the distributive state is what's driving this person's hypotension. And then the real power of ultrasound is that I get to repeat my scans iteratively. And I get to say, all right, now 24 hours of antibiotics later, let's see where we're at. And I can say, oh my gosh, now their ejection fraction has decreased from yesterday to today. I think we might be moving into that post-volume overload cardiogenic state that happens after somebody's sepsis starts to resolve. 24 hours being a little bit fast for that, but the whole point I'm trying to make is don't scan once and then lock your differential in there. Scan, do an intervention, and see how it changes over time. That gives you both the opportunity to see whether the lab values are tracking in a direction consistent with the ultrasound, and if not, gosh, that narrows my differential. And to see whether or not my interventions are moving things in a direction that appears to be more towards homeostasis or away from it. That's one quick thought, Chris.
Awesome. And we have another question coming in. In a patient with a low EF, do you have a lower threshold to start pressors over fluids and unspecified shock, even if you have some space FiO2-wise on the vent?
Yeah, this is a question that I feel like is a callback to the fact that when we look at patients and how much volume they receive, anybody who carries a chart history of heart failure gets less fluids. And that makes sense, right? We know that they're more vulnerable to volume overload and likely to have volume overload occur with a steeper, extravascular lung water will appear with a steeper curve on that kind of Frank Starling and inverse Frank Starling curve that we talked about earlier in the talk. So yeah, I want to be more careful. That said, when we look back at these patients as a large cohort, they tend to probably get under resuscitated. And this is where ultrasound wins again. I get to look at them and say, my main fear from giving these people fluid is it's going to spill into their lungs. But if they have no B lines, then I can say, I'm not afraid of that right now, and give them small boluses and then check again. And if I get to see in real time those B lines appearing before they become hypoxemic, I can get them adequate resuscitation, whatever that means with the grayscale about it, without having to worry about the damage that gets caused by significant volume overload. I get to watch really closely. Just because a patient has a low ejection fraction does not mean that they don't also have the potential to benefit from fluids. It just means that you want to be checking more frequently. And again, I think of ultrasound as being a little more rapid, a little more accurate than my pulse oximeter in knowing when I've started to have water spilling into the lungs. And gosh, the first time you do a lung ultrasound, it seems like it takes forever. But as you get used to this hand positioning and just where the probe goes, the dance that you do, it's literally a 60-second test. And you do that while you're also checking cap refill. You're in the room, you're bonding with the patient and their family. It's bringing us back to the bedside. It's making us feel the connection with clinical care that got us into this industry to begin with.
Great. No current questions at the moment. We can wait around for a little bit more. Like I said, you can put those questions down in the Q&A box at the bottom or the side of your screen. Cameron, any other things that you want to talk about when it comes to undifferentiated shock?
Yeah, well, I'll offer the kind of cool thing that I'm thinking about right now, and I'm curious if anybody wants to take this and make a project out of it. I deal with a lot of patients where their IVC is collapsed because of that false positive I talked about of intra-abdominal hypertension because of tensicytes. And I'm trying to figure out in these patients whether their IVC is collapsing because they are relatively hypovolemic, whether they're in a distributive state, or if it's collapsing because of the fluid on the outside. And then the thing that I think is interesting is I am fascinated by these disparities when the POCUS findings don't match up to the simple story that we learn about this is what all volume overload looks like, this is what distributive shock looks like, this is what cardiogenic shock looks like. And when you have somebody who has elevated neck veins, but a totally flat IVC in the presence of ascites or in the presence of intra-abdominal bleed, this is where I start thinking, oh man, is this intra-abdominal hypertension? How else do I get signs of volume overload in the SVC while signs of volume underload in the IVC? So I like this thought process of saying, hey, let me start to do these combinations. This is all separate from the people who have gotten much more specific in their ultrasound interrogations, and they're able to put spectral Doppler on organs like the kidneys and the liver and start to say, hey, am I seeing a pattern of resistance in the renal arteries consistent with anasarca or venasarca? Am I seeing a pattern in the hepatic veins consistent with regurgitation in the absence of a valvular pathology? All these start pointing you towards more subtle and technical indicators of volume overload. You can put these together into a scoring system that's described by some people as VEXUS. I don't use VEXUS in most of my shock patients because mostly I'm trying to figure out etiology of shock, fluid tolerance, fluid responsiveness, and then is my intervention making things better or worse?
All right, that is fantastic information. It looks like we don't have any more questions coming in. So, Dr. Basson, thank you so much for being here, and thank you so much for the incredible information that you shared with us today. We really appreciate it.
So happy to be here, Chris. Thanks so much for having me.
Awesome. Once again, we'll be doing a second webinar with Dr. Baston on Tuesday, July 1st at noon, entitled Lung POCUS in Critical Care. And we would really love it if you joined us for that. You can see the webinar QR code here. If you go ahead and scan that, that'll take you to sonosite.com/behind-the-scan webinar. Thank you all so much for joining us today. We really appreciate it, and we'll see you at the next one. Thanks again, Cameron.
Bye.